Good afternoon, everyone. Welcome back from the first round of parallel sessions and also from the lunch. We hope you enjoyed both the first round of sessions and the lunch. And it's my pleasure to introduce the first plenary. Every day it will be a plenary around noon. Please check the schedule. And the first plenary of this conference will have an ambitious theme called Health Inequalities in 2030, anticipating scenarios and solutions. And in order to present the speakers and to moderate the session, it's my pleasure to introduce the moderator of the session, the facilitator of the session, Dr. Marius Ungureanu. Marius is the chair of the Department of Public Health and director of the Center for Health Workforce Research at Babeș-Bolyai University. Marius, you have the stage to moderate the session and to introduce the speaker. Good luck.
Thank you so much, Theodor. Welcome to this first plenary session. I know that it's always challenging to have a session right after the lunch, but we'll do our best to keep you awake. And in the best manner, we have a lineup of excellent speakers here, so rest assured that will keep your interest and attention awake. As maybe you have seen in the program, we have a rather atypical structure of this session, because the keynote speech will not be delivered by a person, but the keynote speech will be delivered by ChatGPT. So that being said, I will leave you all to see our keynote speech, and then I'll be back with introducing the speakers and their contributions.
Ladies and gentlemen, esteemed colleagues, and distinguished guests, greetings from the year 2030, a time marked by both progress and persistent challenges in the realm of health management. As we gather here today, I am compelled to share with you a snapshot of the health landscape as it stands in this pivotal moment. In 2020, the world was rattled by a pandemic that shook the very foundations of our healthcare systems. It was a wake-up call, laying bare the deep-seated inequities that have plagued our societies for far too long. Now, a decade later, we find ourselves grappling with the consequences of these disparities, which persist and, in some cases, have worsened. In 2030, health inequalities continue to be a defining feature of our society. Despite remarkable advancements in medical science and technology, access to quality healthcare remains unevenly distributed. Across Europe and beyond, socioeconomic factors continue to exert a powerful influence on health outcomes. From income inequality and educational disparities to housing instability and environmental hazards, these determinants of health shape the life chances of individuals and communities. In this future reality, we see stark contrasts between the haves and the have-nots. In affluent urban centers, state-of-the-art medical facilities offer cutting-edge treatments and personalized care, catering to those with the means to afford them. Meanwhile, in underserved rural areas and marginalized urban neighborhoods, access to even basic healthcare services is a daily struggle. Limited transportation options, shortage of healthcare providers, and lack of insurance coverage conspire to create barriers that are difficult to overcome. Moreover, the burden of disease falls disproportionately on the most vulnerable among us. Ethnic minorities, immigrants, and other marginalized groups face higher rates of chronic conditions, infectious diseases, and mental health disorders. Discrimination, stigma, and social exclusion further exacerbate their health disparities, perpetuating a cycle of inequality that is difficult to break. In 2030, we also see how climate change exacerbates existing health disparities. Extreme weather events, rising temperatures, and air pollution disproportionately affect low-income communities and marginalized groups, leading to increased rates of respiratory illnesses, heat-related illnesses, and vector-borne diseases. As we confront the intertwined challenges of health inequalities and climate change, we must recognize that these crises are interconnected and require integrated solutions. We cannot address one without addressing the other. We must adopt a holistic approach that prioritizes both environmental justice and health equity, ensuring that our response strategies are inclusive, equitable, and sustainable. But perhaps the most alarming aspect of this reality is the widening gap between the health outcomes of different socioeconomic groups. In 2030, we see a divergence in life expectancies that is driven not only by socioeconomic disparities but also by the uneven distribution of health technologies and artificial intelligence. While these innovations have the potential to revolutionize healthcare delivery and improve patient outcomes, they also risk exacerbating existing inequalities. Inequities in access to health technologies and AI-driven interventions further widen the gap between those who can afford cutting-edge treatments and those who cannot. Affluent individuals and well-resourced healthcare systems benefit disproportionately from these advancements, while marginalized communities are left behind. Moreover, biases inherent in AI algorithms can perpetuate disparities by reinforcing existing stereotypes and overlooking the unique needs of underserved populations. Looking ahead, we must confront these challenges with a sense of urgency and determination. We cannot afford to ignore the impact of health technologies and AI on health inequalities. Instead, we must ensure that these innovations are developed and deployed in a way that promotes equity, fairness, and justice for all. This requires thoughtful regulation, robust oversight, and meaningful engagement with communities to ensure that the benefits of technology are shared by everyone, regardless of their socioeconomic status or background. In closing, let us remember that the future is not set in stone. We have the power to shape our destiny and create a world that is more just, more equitable, and more compassionate. Together, we can build a future where health inequalities are a thing of the past and where every individual has the opportunity to thrive. Thank you for your commitment to this vital cause.
Now, I don't know your opinion about this message from the future. I don't know how many of you see it as an optimistic message or how many of you see it as a pessimistic message. I believe there are mixed, I personally have mixed feelings, but I was personally impressed by how pessimistic at some point the message is. And so I really liked one thing that ChatGPT said towards the end of the speech, and that is, the future is not set in stone. So we are now in 2024. We have still a bit to go until 2030. And so our challenge is to make sure that the situation that we've seen could happen in 2030 will not be happening. And so what we aim to do with this first part of the plenary session is to give the word to our esteemed speakers. And we have here a great mix of expertise and professional backgrounds and institutional affiliations. And the question is really this one: how can we make sure that the future that is foreseen by ChatGPT with regards to health inequalities in 2030 will not be the reality? We want and we dream for a better future, for better outcomes for the population. How do we do that? How do we get there? And so let me introduce you the speakers, and then I'll give the word to the first speaker. The first speaker is Professor Federica Morandi, and Federica is a professor and director of the academic programs at Altems, Graduate School of Economic and Management of Healthcare Systems at Università Cattolica del Sacro Cuore, and she's also a chair of the Scientific Advisory Committee at the European Health Management Association. Thank you, Federica, for being here. Next, we have Dr. Tuomo Nieminen, who's the Chief Medical Officer, Wellbeing Services County of... I will not pronounce that because most likely I will not pronounce it correctly in Finland. We also have Ms. Julie Spony, who is Policy Officer at the European Patients Forum in Belgium. We also have Dr. Eva Turk from the Minister's Office of Slovenia and a board member of Health Technology Assessment International, a senior researcher at the Center for Digital Health and Social Innovation, University of Applied Science, St. Pölten, Austria and Slovenia. And last but not least, we have Dr. Thomas Zapata, who's the unit head of the Health Workforce and Service Delivery at WHO European Office in Copenhagen. So without further ado, I would like to give the word to the first speaker. I invite you to be seated and give your your thoughts that will then feed into the second part of the plenary session, where we aim to have a bit more engagement with the audience. We'll be receiving questions from the audience and then allow for you to interact as panelists. So, Federica, you have the word.
Good afternoon. And first of all, I say thank you for this invitation and for the opportunity to be here to discuss with so excellent colleagues about this very challenging topic, health inequalities in 2030. So I can say that 2030 is quite now, more or less. And as a scientist, I can say that if we want to eliminate and if we want to change the scenario and mitigate or really eliminate the health inequalities, we need to start working now, or better, from yesterday. I'm here, and as you have introduced me, I come from Italy, so I bring the perspective of my country, but more or less it's quite similar for all the other countries in Europe and worldwide. And I am an academic, so I will share my experience as a professor, and specifically in human resource management in healthcare. And I would like to bring here three main points to address. The first one is the shortage of healthcare workers. This isn't just, in my opinion, a problem of numbers, but it's about optimizing the health workforce. By 2030, we can't afford to wonder why no one wants to be a nurse anymore, or why emergency doctors are scarce. And as a human resource scholar, I can say that we have a recipe. And we need to look at the two main basic factors which drive the motivation of people, of workers, which are the intrinsic factors of work that are related more or less with the content of the work, and with the extrinsic factor of the work, which are related more or less with the results of the work. So looking at the intrinsic factor, we need to completely rethink and reframe the tasks by adopting the task-shifting approach and methodology. We need to make roles more interesting and sustainable in terms of work-life balance. We must minimize the perception that workers are wasting time on uninteresting tasks. And on the other hand, even though we know that healthcare professionals are driven by a very deep vocation, we need to look at the extrinsic factors, because also the extrinsic factor matters. And I mean with the extrinsic factor to career perspectives, to compensation dynamics. So we need to guarantee that young people, that young scholars that are applying for healthcare careers can work in a very sustainable way, growing both in terms of status, so in terms of career, and growing both in terms of their earning. Otherwise, the risk is that the decision to study healthcare subjects and then to work within healthcare organizations will progressively decrease. Second aspect is dealing with the AI. Artificial intelligence can be incredibly beneficial. And from a role design perspective, because I am a scholar in human resource management, so I put this perspective, I think that AI can really help to really act the task-shifting approach. For example, freeing healthcare professionals from duties that eat into their valuable time. Let's think, for example, to the administrative and to the bureaucratic tasks that healthcare workers need to accomplish in their daily activities, which may give them the perception of dedicating time to not to their patients, but to other tasks that are very not interesting and they take so many time and they are a sort of wasting time. In addition, AI can support diagnosis and care of patients, but it requires a proper training because we need to use it effectively. AI won't replace the work of people, but we need to learn how to correctly manage it and how to efficiently manage it. And AI can also support the decision makers. Data from the history of healthcare systems, including challenges, successes, failures, can feed the real-world data and in turn can provide the opportunity to have a precise analysis of future scenarios. For example, if we know the past, if we think about the COVID-19 pandemic and we consider the decisions, the choices that have been taken by healthcare systems, we can use all this information to provide a clear strategy for the future. Lastly, I have a third point, which in some way ties the first and the second. And the third point are skills. As a university professor, I see that, and I can affirm that competencies are the key to solve more or less all the problems. We need to rethink the roles in healthcare. We need to redistributing tasks. We need to enhancing profiles with new skills to make more attractive the roles, especially for young people. But working on skills also means completely rethinking to the training path that must be oriented towards the integration and collaboration between different professionals. As our keynote speaker subtly indicated, we experience inequality if the health systems are disintegrated, if there is no communication between different levels of care, and if people are left alone or unaccompanied in their patient journey. Because we know that patient journey, patient process are designed on process, of course, but we need people that are able to act this process, that are able to work together, and they need to be happy to work together from the very young age. They need to acquire a common language and experimenting the interaction among between different professional profiles since the beginning. So it means since the very beginning of their career as students during the bachelor degree. So this involves rethinking the training path to foster the integration and collaboration among different kinds of professionals. And we must also address to the managerial competencies because I think that managerial competencies are crucial. And I think that healthcare workers and healthcare professionals deserve excellent managers, which means having leaders who are not just technically proficient, but are also skilled in terms of communication skills, in team working, in leadership, and in this way, the good managers can impact the sustainability, the process fluidity, and the quality of care. So if we look at all this perspective together, so workforce shortage prevention, effective use of AI and big data, appropriate use and development of knowledge, I think that we have a sort of guide and about how to avoid health inequalities. So thank you.
Thank you. Thank you, Federica. I believe this is a really important piece of the puzzle because it really is a puzzle. So moving forward to you, Tuomo.
Yeah, good afternoon, and thank you for the presentation to be here. So, I represent here a public provider of healthcare, so my perspectives mostly come from there at this point here. So if we think about the general health and well-being level in Finland, it has clearly increased, like in just about in every European country and elsewhere also. But still, within the last decades, for example, the mortality, if we think about different social economic groups, that gap between the most prosperous and those who are at the other end, it has even become widened at the same time. Even so, we have more and more possibilities to tackle with almost all kinds of social and healthcare and well-being issues. And if we think about what we should be doing there, we should be able to have very similar, equal healthcare system for all of the people. And in some of the countries, like in the country where I come from, the public healthcare system, it's relatively, or it's very equal actually. So if people come to our system, they are treated treated in the very same way, regardless of which social economic group or for whatever type of group they come from. But then we have, like in many other countries also, we have at the same time many different levels of healthcare or different systems. We may have a private healthcare system where we can go if we pay with our own money, and probably public system pays some part of that also. And then we may have occupational healthcare like we have also in Finland. And in our system, that's actually one of the main system, which makes the system unequal. So that those who are working, they generally have a better system for healthcare, for the primary healthcare. Even those patients, in many cases, they come to public specialized healthcare if they have some serious health troubles. But then, even though we wouldn't have any of those, we still have inequality. There are people who don't come to our system, we just don't reach those. And we would have some possibilities. For example, we have huge data sets in our very system, because those people, they have sometimes come to us, and we have all kinds of data about them. But then, at this point, in many countries, there are some legal issues where we cannot make any automatic decisions about whether we should invite certain people to come to certain tests or to come to see a nurse or a physician. And those legal issues, those certainly should be tackled by 2030 in a way which is ethical, and of course data security issues need to be tackled. And so if we are thinking about this healthcare system, we certainly have many different systems in different countries, and quite a few in quite a few countries they are not very well integrated. So the primary care might be very much different from public health work, and the specialized health care might still be in totally different hands and in totally different organizations also. And in most cases, I would give a bet, the data does not follow very nicely. We lose efficiency there, and if professionals in certain different places, they really don't know everything what is needed to treat the patient in the optimal manner. So integration, whether it's organizational or whether it's based only for the data to follow, that should be something which should be much better in about 10 years from now. So I guess there are many different aspects also, but probably I will just stick to these ones at this point.
Yes, thank you. Thank you so much, Tomo. I really liked your mention about evidence-informed decisions and also about integration. And these are two aspects that we'll pick up on later during the discussion. Now, giving the word to Julie, please.
Thank you very much, and good afternoon, everyone. I'm very happy to be here because health inequalities is a crucial issue for the communities I represent. So I'm from the European Patients Forum. We are an umbrella organization of patient organizations across Europe and across disease areas. So you understand why health inequalities is crucial for us. And to kick off the discussion, I would like to start by defining the topic from a patient perspective, and then I will give you some thoughts on how we can anticipate the scenarios and provide solutions so we don't end up with the scenario that was underlined by ChatGPT. So as you all know, health inequalities are highly influenced by the social determinants of health, like income, economic stability, but also access to quality of care. And this is the aspect that's crucial for patients with chronic conditions, because patients with chronic conditions are in a vulnerable position due to the effects of the illness itself on themselves, because they are often very serious and disabling. So patients with chronic conditions are highly dependent on having access to safe, high-quality, continuous and integrated healthcare, because healthcare is a significant determinant in well-being, and it makes people live longer and have a healthier life. But I would like to define with you what access to healthcare means, because we hear it a lot, but at TPF, together with our members, we define access to healthcare according to 5 principles. And I think in all the strategies we will put in place to address health inequalities, we need to consider those 5 aspects. So the first one is access needs to be available. So treatments, including specialized care, needs to be available to all patients. The second principle, which is also very important, is adequate. It relates to quality of care, and it means that healthcare needs to be constantly adapted to patient needs. The third principle is accessible. The treatments through early prevention, health promotion, and healthy promotion to all stages of treatment needs to be accessible to all patients. The fourth principle is appropriate. The healthcare needs to be appropriate to the different population and a group of patients, as healthcare needs to be inclusive. And the last, but definitely not least principle, is affordable. Patients should not suffer financial hardship as a result of seeking treatment. So now that we have defined those 5 principles of access, you can see that even if it's a basic EU citizens' right, this is not yet a reality for all of us. And we heard it with ChatGPT. In 5 years' time, those health inequalities are most likely to be exacerbated. And although, from a patient perspective, we don't have our say in all the policies, I would like to give you some takes on where we can act. So at the system level, we need to have a health inequalities in all policies approach with targeted strategies. And here there are 3 things from a patient perspective that we can do. The first one, the 2 first ones go hand in hand. It's patient empowerment and health literacy. These are crucial aspects of tackling health inequalities. Patient empowerment, for those who don't know, is the process through which a person is increasing their capacity and drawing on their personal resources to live longer, to live better, to manage their chronic conditions. And a key aspect of patient empowerment is health literacy. And health literacy is the ability of a person to make sound health decisions. And it's crucial to tackle health inequalities because it has been shown that people with high level of health literacy are more adherent to treatment. They are also better communicating with their healthcare professional and so on. And conversely, low health literacy is associated with low adherence to treatment, but also it can lead to misdiagnosis or medication errors because there are poor communication between the patient and with the provider. And when we talk about health literacy, we also need to address digital health literacy because as we heard with ChatGPT, and this is already the case, there is a digital divide between patients who understand and can access health technologies, and those who cannot. So we need to invest capacities and trainings in improving digital health literacy. So those two aspects of patient empowerment and health literacy are the first aspects that can help tackling health inequalities. And the last one I would like to bring to the table is not less important. It's actually crucial. This is patient involvement, because patients, they are the end users of the health systems. They are a key resource we need to build on to improve our health system and address health inequalities. And today, this is not the case. We are not using patients enough to find solutions and to build a system that will work for everyone. So we need to use patients and really involve them from the development to the evaluation of healthcare. And that's my last take on how to improve health inequalities. Thank you.
Thank you so much, Julie. I really liked what you mentioned about the 5 A's, the availability, adequacy, accessibility, appropriateness, and affordability of services, and also how you tied it all in this health inequalities in all policies approach, which will come back during the discussion. Thank you. Now, moving on to Eva.
Yes, I think I'm going to be building on what you said, Julie, but for me, it's also something that I was reflecting a little bit. Most of you probably know late Professor Hans Rosling, and he said like that we are actually in the best place in the history of time today. And he also said that he's not an optimist or a pessimist, what we heard, but he's a possibilist. So in a way, it is about for us to find the possibilities, and what we are discussing here today is one of the possibility, right? To how to move forward. The fact is that business as usual is not an option, because in this case we have a dire 2030. So what can we do to actually feed ChatGPT in 2030 with better data and to have a better outcome? And for me, it's a lot about the way we tell, or we have to change the narrative. I think it's often in a way how we disseminate our knowledge. We had today the masterclass on knowledge brokering. But we still need to go beyond patients. We need to go to the citizens, because this is how we create health, and this is where our values are lived. So somehow, in a way, the group that I'm leading at the University of Applied Sciences is Inclusive Digital Community Care. And I have been in the last months working quite a bit, or reading more into the work of Cormac Russell on asset-based community development. So the idea here is really to start with what's strong, not with what's wrong, and to see what are the good examples that we can take from different countries. I know that we cannot apply one-on-one or whatever, but we can learn from each other. And I think for me, a story about fighting malnutrition in Vietnam comes to mind. Maybe many of you know it already, but it was always the same story. It's poor people, they are not educated, children, 90% of the children are malnourished. We don't know what to do. We have tried so many things. So Save the Children sent a doctor there, and he said, like, I'm fed up with hearing the same story all over again. So if 90% of the children are malnourished, what happens with the 10% of the children who are healthy? And he was observing what are the mothers of the children that are healthy doing different than the rest. And he figured out that the mothers of children that were healthy fed their children with some kind of like shrimp that was not supposed to be eaten by children. And those children were healthy. So what he did is that he collected the mothers taught other mothers. And through that, actually, it was the malnutrition. You probably know the story better than I do, but the malnutrition within a couple of years was abolished in the Vietnamese villages. So I think this is for us to finding the lighthouses in a way to say what works well. And, the digital component here really, really serves us well. We all use it. We all count our steps and so on. I'm not saying that this is going to help inequalities per se. Of course, it's going to be many different things. But in a way, if we start looking into what's good and have a positive note, you see, I'm not only a possibilist, I'm an optimist. I think that we will also be able to feed the data in a different way than what we have heard today. So on that note, I will give it to WHO, who can then take the responsibility. But thank you so much for listening.
Thank you so much, Eva. I'm really hoping that we'll end up in the best possibilities in the best possible scenario, so to say. So, at the core, I'm an optimist. In fact, although I said that I became quite pessimist when I've seen the speech from ChatGPT. And one other thing that it really stuck with me, of course, working in public health, I really like what you stressed on the importance of looking at citizens, not only patients. I mean, when you have the citizen-oriented approach, we can achieve a lot more, but we'll bring that to the discussion a bit further on. And last but not least, WHO. So Thomas, now after what Eva said, maybe your job is even harder. Thomas Zapata, you have the word.
Thank you, Marius. Actually, it's harder after everyone before. For me, I would like to bring first the inverse care law, since we are talking about health inequalities. The landmark paper written by Tudor Hart, a GP from Wales in 1971. And basically, the inverse care law, what says is that the higher a specific population needs have, the lower the services provided to that population, a specific population. And I think we are still struggling with this. This was in 1971. He could prove that. But I think we are still struggling nowadays with the same challenge, the increasing inequalities and health systems and health services not being able to respond to that. And I think one key factor on those inequalities is health workforce. We started with health workforce and we'll finish with health workforce, because I think health workforce is a critical element to really address those inequalities. And I think this is affecting cross countries and intra countries. If we look at cross countries, in our report last year, Health and Care Workforce in Europe, Time to Act, we could see that the availability of doctors, for example, in Tajikistan, in Central Asia, is 3 times lower than the availability of doctors in Greece and all other EU countries. So we see those inequalities across countries. The same for nurses, even worse. It's 8 times lower the density of nurses in Central Asian countries than in the western part of the region, in the European region. And we also see those inequalities inside countries. If we look, for example, at the split of rural and urban areas, we really see increasing challenges in terms of accessing and quality services in rural areas, and increasingly difficult to deploy well-motivated, well-trained health workers in rural areas or underserved areas where socioeconomic people are really deprived and health workers not willing to work there. Another dimension of that intra-country inequalities, I think, is by level of care. We also see that in many cases, primary health care is really struggling to attract talent and to attract health workers, and also at the community level for long-term care services, whereas hospitals are really able to attract a lot of health workforce. So I think we also have another level of inequalities within countries, rural, urban, underserved, but also depending on the level of care. So I think that's something that we really need to look forward, because we know that health workforce really play a critical role in improving access to quality service and at the end of the day to improve health outcomes. What we see in our region is that we have a health workforce crisis in most of the countries, basically because we have an aging workforce, one. Second, we have high levels of migration as well in different countries, which is really affecting. Romania is one of them. Third, we see increased levels of burnout that are really affecting the workforce willing to leave and not being able to attract the new generations as well. And on the other hand, we see an increasing demand is what we are seeing all over the region. Increased demand because of an aging population, multimorbidity, backlogs from the COVID pandemic, and also an increase in consumerism by patients. So what are the solutions that we are bringing from WHO? We came together with all member states, 53 countries, and we developed a framework for action. And that framework for action really puts at the center the health and care workers. And the first step is retain the health workforce. It's how we improve the working conditions so we are able to keep those health workers in the system so that they are willing to work there, and more specifically in those rural and underserved areas, in primary health care, in long-term care. So I think we need to have an specific focus and really put packages of incentives and non-financial incentives to make more attractive those health workers to work in those areas. I think you were discussing, Federica, about intrinsic and extrinsic factors, so we need to apply this to this. And the second pillar is about optimizing performance, and I'm not going to get into that because Federica already described it much. And the third pillar is about building the supply, how we bring the right competencies, the right skills, so that we have a fit-for-purpose workforce for the future, for that 2030 that we were talking about. And the last two pillars is about building, is about improved planning. I think we are always kind of passive. We are always behind the curve. And now I think we need to be proactive. We need to plan ahead what will be the needs in 2030 on health workforce in these specific areas with higher health inequalities, and how we plan for that. And the last pillar is about investment, how we increase investment, how we position health workforce as a central political item so that it capture budget and it capture attention by policymakers in order to move forward. And with that is 5 minutes on the dot. Thank you.
Thank you so much, Thomas. Thank you for your passionate plea for a lot more action in the area of health workforce with regards to retention, with regards to optimization. And that's just the perfect end for the first part of the plenary and the perfect beginning for the second part of the plenary, because we're not just here to describe the status quo. We're here because the session is titled Anticipating Scenarios and Solutions. So what we'd like to do in the second part of the plenary is to think of solutions, what we can do in order to not allow for the situation to be in 2030 as described by ChatGPT. And so I have a couple of questions, and I'll be addressing them directly to each one of you individually, but at some point we'll have maybe 2-3 questions from the audience. We're perfectly in time. Thank you for being so careful with the time that was allocated to you. I'm sure that the audience also appreciates that, apart from the content, very nice content. And my first question, I have to say that working in public health, this video from ChatGPT kind of rubbed me the wrong way, at least under one aspect. It mentioned about the medical system, the medical services on the one hand, by mentioning, on the other hand, health inequalities. And I was like, but where is public health? ChatGPT, in 2030, don't we have public health at all? So that is what rubbed me the wrong way. Maybe there are aspects that did same to you, depending on your area of work. But the bigger thing that I want to raise here is what are currently our blind spots as you see them, and how can we address them? Because it's, as I said, I want us to focus on solutions. And so maybe I'd like to give the word to you first, Thomas, because you ended the series of interventions and you mentioned about optimization and you mentioned about professions. And so linking back to what rubbed me the wrong way with regards to public health, but broadly, primary and community care, what can we improve there at the level of community, and also linking with the remark that Eva had with regards to citizens? So what can we do in order to not let the situation advance to what ChatGPT described in 2030?
Thank you, Marius. I think something important is bringing the patient's perspective. You were mentioning about that. And I think we need to take much more into account the communities and the patient's perspective, and also the health workers' perspective. You want to find tailored solutions for the problems coming from the ground. I think in many cases we are designing policies that are very much top-down, and we are losing the grasp of the of the real solutions that could come from the ground. So in that sense, I think giving more autonomy to the teams on the ground who knows what the solution could be, really engage and insert it in the community and trying to find ways on that, I think that's something that can really help. And then linking to optimizing performance, I think in this way, rethinking ways of providing services, bringing digital health technologies in a way that can really maximize the limited number of human resources that we have on the ground can really play a role. And we have some good examples in Sweden, in other countries that they are really using these digital health technologies to improve that, and expanding the roles of different health professionals. Nurses, for example, they can really play a much bigger role. They can work to the top of their practice, and they can really make a much bigger contribution on the ground. Just some thoughts there.
Yes, thank you. So if I get it correctly, is in a way redefining the boundaries that we had so far, because yes, boundaries are helpful, but many times are limiting what we can achieve. And I believe in this regard, we really need to rethink that. And of course, there are many examples, some of them you mentioned, but there are some others in task shifting, task sharing, so on and so forth. So Eva, because we were mentioning citizens, how do you see things in that perspective? How can we do more in that regard?
I wanted actually to build on what you said, because when we engage communities, communities are people. So it's all about finding ways of co-creating different solutions. We try to do that when we develop some kind of digital solutions in our group. But I think it's really with regard to going to the citizen science. And we talk so much about evidence, and we are beyond the old evidence generation, right? We are generating real world evidence. It's about the observational data that comes actually from the citizens and so on. So I think in this respect is I'm gonna go back to the health literacy, because we will be able to empower people, and if we start from the communities, we need to start in schools. We cannot talk about healthcare, obviously everybody knows that, without social determinants of health. But we are not really good in putting health into the schools and educating youth with regard to this. We are not really good in how can we better use social media and the easy digital health, let's put it like this, with regards to telling the story. It's much easier to, for everybody to follow TikTok or different social media that some influencers tell what to do, right? So I wonder if, we need to find a way how to be those influencers, how to make the story really punchy and interesting and so on, because it has to go both ways, right? So what we say, it goes top down, but it's a lot from bottom up. And we have seen a lot, especially when it comes to innovation in different areas, how things work. So we can also be better in taking things from maybe different industries. We've done this in patient safety a lot, but we can also work towards that.
Yeah. Thanks for that. But and it also, I fully agree with that, Eva. And it also takes me to something else that I looked at what ChatGPT was saying, and I believe that maybe we're not doing a great job at that currently, and we need to think of what we can improve with regards to the fact that we know, and you were mentioning social terms of health, and we know all of the factors which have an influence on the health status of the population. But still, to a large extent, we work, each one of us, in our own fields or in our own sectors. And as we could see from 2030, there will be widening health inequalities. There will be specific challenges coming from climate threats and also artificial intelligence. And I don't know if you've seen that, but as when I landed today in Bucharest, I received this notification that there was this letter written by 11 former and current employees of some of the companies active in artificial intelligence, calling for more regulation with regards to artificial intelligence, and it was quite a very serious announcement. So how do you, maybe moving forward to Julie, to Tuomo, to Federica, how do we work more effectively between sectors? Because yes, we know that even in the health sector, we still have a long way to go to work more interprofessionally. But even moving forward, or taking it to the next level, how do we work better between health and finance, health and environment, health and education, health and sustainability? You name it. How do we do that? So I don't know, Julie, Tuomo, Federica.
Thanks. That's a very good question, and I'm going to build on what has been said also before. I think on how to engage with other sectors is also the same key issue as on how to engage with stakeholders. It relates to involvement, but meaningful involvement and co-creation, because we heard that's how we can engage with the broader public, but also that's how we can reach out to other sectors. And when I say meaningful engagement, I don't only mean like just a consultation, because as a patient organization, we are consulted on many things, but sometimes it's only a survey or like a consultation at the end of a process. So our input is not really taken into account, and it's sometimes a bit of a cherry on the cake, but they just tick the box and said, oh, we consulted patients. So when we want to interact with other stakeholders, be it in the health sector, but also in other sectors, we really need to meaningfully engage and to be sure that all the actors are there from the beginning, and that we don't end up with regulation that will, for instance, ignore health. It reminds me of this AI Act that you are, I'm sure, all familiar with. Health is not mentioned anywhere except for high-risk medical devices. But the healthcare sector is absent of the AI Act, and that's an issue. So if healthcare partners, stakeholders were engaged from the beginning, maybe that will not have happened. So one of my key messages here is to really say we need to have all the stakeholders involved from the beginning, and to be sure that they contribute to the agenda, they contribute to even the thinking before the legislation. So we make sure that healthcare is reflected everywhere.
Yes, thank you so much. That's just really important, not to have people at the table just to tick boxes, just to say that, oh, we achieved that, we have those people, they vouched for what we've done, but really to engage them from the very beginning of the design of the process.
Oh, and when we are talking about health, well-being, public health, and nature, climate, so we are talking about planetary health, and that coined is termed something like 8 years ago or so, and since then there's been an expanding interest and expanded set of actions taken in quite a few countries actually, where the idea is that what is good for health, well-being is also good for nature. So in a way it's also less social media and more contact to nature, and such actions should clearly be increased, and that's certainly one of the next great waves of public health. For example, reducing the rate of mortality to cardiovascular diseases, it has been a great wave of in public health since the last 50 or 60 years or so, but the next wave will be clearly different, and it's related to planetary health. And if I also may mention something about the efficiency aspect of our systems, then one thing is that less is often more. We make all too many kind of imaging and examinations for quite a few people, and we treat much too actively many of our patients, and also we lose resources such a way. So we should be clearly be thinking about what we get out of the treatment we give.
Tuomo, just a very quick follow-up question, and then Eva wants to continue, and then Federica. Let me ask you something. So you were speaking about planetary health, and we know how this is, well, we are discussing increasingly about planetary health. But let's keep our feet on the ground. How do we really get to where policies are taking that into account? I mean, let's think of many of our decision makers. Many times we have difficulties in doing the very small things like integrating health and social care services, which is not really rocket science as you think of it. And so my question to you is, how do we sell that, if you like? How do we sell planetary health? How do we see the reality, and how do we see the reality on the ground, in the decisions that are made, in the policies that are being taken, in the financing? Because it all comes down to the resources. How do we do that?
Yeah, I would say it's actually quite easy to sell the concept of planetary health at this time when quite a few people, particularly the younger ones, they have great anxiety and distress about the climate. So I would say we are quite eager to do something to make the situation, the climate better, and at the same time also improve our own health and well-being. But that being said, so the term planetary health, it may not bring anything really new regarding the public health itself, but it should employ quite a few of those earlier aspects of public health, and those should be incorporated in common policies which are related to climate prevention of changes there.
Thank you, Eva and Federica.
Just to, I don't think we need to sell. I think it's about co-creating. We need to build ownership. I think it's very important that kind of like we have this buy-in from the start. But what I wanted to say is also with regard to the perverse financing that we actually have, right? We our hospitals mainly, or the doctors are paid to do as many services as possible. I spoke. I'm not a clinician, but I spoke with many clinicians, and many say the most difficult thing is to say you have a healthy child, and there's nothing wrong with your child. So I think our systems have been built to kind of like to protect in a way also the healthcare workforce in that sense, to say, okay, we will try something more, and because we have the sick care system, right, not the healthcare system, we are looking, and I think it's in a way, I'm again on the meta level, and I know that it's difficult to bring it down to the ground, but I do truly believe it is about the story that we tell, and it's about the narrative that we need to change.
I fully agree. We need to change the narrative, because in many situations, as you're rightly saying, we do not think of or work in health systems, but we work in illness systems because we're focusing so much on that. Federica?
I would like to add something to Julie. You said a very interesting thing, that we need to engage stakeholders since the beginning. And I think that this engaging starts from the university, in which different professionals need to be in some way in connection with the others. We need to leave the traditional way of teaching, and we need to add something new. For example, to allow to physicians to know also about artificial intelligence or finance or other or patient perspective, and also the contrary is valid as well. I think that it can be a solution for the future generation. Now we need to find different solutions that, in my opinion, could be, for example, also the creation of a community of practice in which we can create. We do this kind of activity very frequently in our university, and we create community of practice in which people from different field with different perspective discuss about challenges, but also about experiences, and try to find a common point of connection and a common point of discussion. So, in my opinion, it's very important to work on the cross-fertilization and on integration among different professionals.
Yeah, I fully agree with that. And you would be surprised how many great ideas emerge out of that. We in our university have this these living labs that bring together people from many fields in the university and also connected with the community. And we take challenges from the community, be they public institutions or private institutions or NGOs, and then we're working faculty and students to come up with solutions. And it's incredible. You wouldn't think of the amount of energy that goes into that and solutions that come out of that. Thanks a lot for your... Thomas, you want to...
maybe complementing on that one, because I think it's, at the end of the day, it's about how we improve teamwork in the service delivery side. I think so far we have had so many profession-based silos. I think we really need to start bringing together, and I think that's a key critical element, that it starts in the undergraduate education so that people start learning and working together at that level so that they are able to work together later on. And now when we are defining patient pathways across the system, across levels, I think it's really important bringing this teamwork and this coordination element as well, so that all these things are aligned.
Thanks a lot, Thomas. I'm looking at the time, and we arrived at the moment when we can take 2-3 short questions from the audience. I guess there is someone who can help us with the microphone. So if you can raise your hand so our colleagues will see where to take the microphone. And when you ask a question, please introduce yourself, and whether it's a question addressed to one of the specific speakers, please do mention that. And then we really appreciate short and concise questions, and we also really appreciate short and concise answers. And until we have, we have someone there. We can hear you.
Okay, check. Yeah, it works. Yeah, thanks. Frank from Maastricht University. I was triggered by what Professor Frederica said about using AI as a task-shifting tool, especially also for nurses. I was wondering, also looking at my own research, what you see often now is that health professionals and also health organizations are rather skeptical of using AI at the moment because of privacy issues also. Do you recognize that, and do you maybe know of tools or ways that we can use to actually use AI in a privacy protective way, basically, to actually start engaging in using AI in hospitals, for example?
So is this for Professor Morandi?
Yeah.
Okay, perfect.
Okay, thank you for your question. I'm not an expert of AI, okay, but what I can see and what I have seen is that nowadays students are using very frequently AI, and we need to find the right way to apply AI in our courses. For example, in a previous session of how to train future leaders, we spoke about AI, and we tried to reason about how to oblige students to be critical in front of the solutions that the ChatGPT provide. It is in some way what we are doing now. No? We are discussing what ChatGPT has said us during the keynote, and I think that we can use I can suggest to use AI for students to oblige them to go beyond the very formal solution, because I think that human people can reason better than AI, of course, and fortunately. And but we also need to allow students to be able to make the right questions, because when I speak with physicians that use AI, for example, in the oncology area, one of the topic is how you can make the right questions to the artificial intelligence, and how you can effectively use for the patient, for a better care for patients. I don't know if the right answer, but it is what I think.
Tuomo wants to add something to that.
Yeah, thank you. So it seems like at this point there are already quite a few apps or possibilities for AI in a hospital, but mostly they are very, very specialized. For example, they might be regarding how to position the patient for a certain type of imaging, or what type of sequences we take for that specific type of illness or so. And AI make suggestion for about the findings in the imaging and so on. But those are all different AI applications. So I already mentioned 3 different ones. So that's one of the trouble at this point. And general like language models like ChatGPT, they are at this point all too general, it seems like, for real useful, productive use. But well, we are just in the beginning of this AI season.
Thomas, I guess, wanted to add something, and then Eva.
No, for me, not on AI, but on digital health technologies overall, I think they have a critical role to play for maximizing, optimizing performance of health workers. I think there are some principles that we need to have in mind. First is that they respond to health system needs. Because what I see many times is developing like mushrooms of digital health technologies and apps that they don't really bring any added value into the system. And they cost money, and we have to be really careful. And that leads me to my second point, which is very much, so 1, aligning to needs. 2nd, assess the impact. Evaluate how cost-effective they are, how effective they are. So in the same way we are introducing a new medicine or a new intervention, I think we should do something similar for digital health technologies, because otherwise we can go in the totally wrong direction and spend a lot of resources. And 3rd, I think it's really important to engage health workers since the beginning, since the design phase, so that we make sure that they are helpful for them and they are not seen as a burden. And we see this, I was in Porto in the Digital Health Conference, and we had a session on digital health and health workforce, and it was coming out from many health workers. Many of the digital health technologies introduced during the COVID pandemic, they are not used anymore because they are perceived as a burden for health workers. Others not, others are working well. But all I am saying is that we need to engage with those that are going to be using those technologies since the beginning to make sure that they will stay and they will be useful for them and for the system.
And Eva, and when you, after your contribution, I have this quick follow-up question. How do we make these innovations stay? I mean, those which really need to stay, because as Thomas was saying, we've had some things happening during the pandemic, and we were forced to do that, but then they vanished away for various reasons, and some of them, they really needed to stay. How do we change that? How do we make them stay?
I guess we're going to have a session on this tomorrow on the harmonizing the digital health technology assessment on the EDITA and so on. But yeah, that's a question. I think it's always, again, having the buy-in from the financiers in a way, it's also very, very important. So in that sense, I guess I don't have a solution really with regards to, what makes it stay. I think first of all, when we speak about like the easier digital health technologies like the wearables and so on, it makes to be feasible for people to use it. It needs to be user friendly, and it needs to be very easy to use, and it should be a very, very small kind of like effort, if any, needed. Yeah, so it should be in a way seamless. The point that I wanted to make is also with regard to the health workforce education. We are working, or at our university, we are working quite a bit with virtual reality. We worked, it's about, kind of like the paramedics education a lot with regard to that. And there's also, we're just now starting a new Horizon Europe project on XR2 resilience. So it's also working with nurses in particular to see how can we make the healthcare professionals more resilient by kind of like through the virtual reality. So we're going to put them in the different scenarios and so on. And this is also something that, can be part of the education system already, which you mentioned, Federica, before, kind of like looking into the different perspectives, bringing the different parts into the educational system. Because to be completely honest, we are teaching medicine the same way as it has been done for the past 100 years.
Let me ask you, Eva, how well received was that by the nurses, for instance? I mean, I believe you've had, even if the project, you mentioned that it didn't start, but preliminarily, how did they perceive this? Because we have a tendency, we as human beings, to be reluctant to everything that's new. How did they perceive this virtual reality?
Well, actually, this was very well perceived. It was they had fun. It was something new, and it was putting them in a stress scenarios that they usually maybe wouldn't have been in a typical scenario or whatever. So it put them in a different possibility in a way to say, okay, so how would I react in this? But that was from the student side. Now we're gonna see how it works with established nurses.
Great. And I guess Julie, you wanted to add something? Yeah, Julie, and then there is the second question.
Yeah, thank you. Just quickly, I wanted to come back on what was said on engaging with health workforce on AI, because it's not only about engaging with health workforce. Of course, it's important, but it's also communicating the use of AI to patients. There are critical ethical questions underlining the use of AI. I don't have a perfect answer, but we played this game called the Serious Game on AI, where we, with different patient organizations, we looked at the patient journey. And at each point of a patient journey, there was the use of AI, and we were asked, are you comfortable in using AI here, be it for the automation of appointments or to look at oncology scans? So we had to answer whether we felt comfortable with the use of AI, and at the end of the day, it's very personal. So what I would like to stress is health workforce should also engage with patients and communicate and be transparent on whether AI was used, and that's the rational and more practical solution to go with when it comes to the use of AI. And I wanted to emphasize.
Thank you, Julie. So I promised 2 to 3 questions, and I'll keep my word. We'll have 2 questions, and I see that the microphone is already there. So concise question, and we appreciate concise answers. Yes.
First of all, thank you for insightful discussion. And my question is, it's not a secret that in the face of such threats, as we discuss, universal healthcare coverage is put like a priority in all European region. And in our discussions, we address, first of all, centralized public healthcare systems, again, like a priority. Where and how you can describe the place for private healthcare in this ecosystem, if any? Because in my opinion, in many cases, private healthcare providers may be those who more easily, more quickly bring innovations from theoretical field to practical field, or no?
Okay.
What is your opinion?
Good. So we got a question. Who wants to try and answer to that? I believe this is quite aligned with what we've been mentioning, that we need to work with various components of the health system and also across systems. And of course, the private component of the health system is really relevant here. So anyone wants to maybe, Tuomo, concise answer? We were about to end.
I would say that if the public health system is very wide in a country, then it's very likely that the system is also technically very advanced in quite a few countries, actually. So they take the technology, we take the technology, what is the very brand new, at least at the same level as in the private sector. And the private sector, it's driven mostly by the financial benefits. They make the decisions based on what is best for their own economy. So that's one of the great dividers here, I would say.
Thank you, Tuomo. So we are just 1 minute before the end of the session, and I'd like to, first of all, thank you. I will not summarize what we've discussed because there was so much, but I'll just say that everything that you threw in here and also through the questions is like an ingredient to a cake, and it can't be, I don't know how many of us are great cooks or have had chef lessons, but it can't be a good cookie or a bad cookie. So at the end of the day, we hope that in 2030 we'll have a good combination of these elements. But before we end, I'd like to just address this challenge to every one of you in just 2 words. What will you do differently when you will leave the EHMA conference, not with your organizations and institutions, because there are great things that you do organization, institution-wide, but you as an individual, in order to move towards the future that we like to envision with regards to health inequalities. And I'll start, and I have to admit, I'm sneaky. I thought about this, so I have well-prepared answers as opposed to you who didn't know about this. So what I aim to do is to increase awareness by writing more about this, because I believe we need to elevate it to a higher level at the public discourse. So Thomas, you finished. Now I kindly ask you to begin. Very short, 2 words, and then moving towards a very
price question. No, for me, keep working as we are doing in supporting countries in implementing the framework for action and moving from a health workforce crisis to health workforce success that can contribute to improve the health system quality and the health outcomes.
I'll start with myself and try to get in the 10,000 steps a day, and to work towards my health promotion, because I do believe that we also take the individual responsibility, and kind of like going then to the ministry in a way. I think it is really trying to bring the story in a way that everybody can buy in.
Thank you. If I start with myself, I would say that I will keep raising awareness amongst my friends, my family, about health inequalities and how we can do what we can do to address them. And within EPF, I will also keep working in advocating for patient involvement in EU health policies, but also will reach out to health workforce organizations to see how we can work hand in hand.
Yeah, health promotion, that's the key. So we will continue to promote the health also to those people who have not employed it that well as the others.
Yes, I meet a lot of students every day of different levels, so I think that I want to make them more aware about health inequalities and to bring on the table of the discussion all the topics that we have discussed today.
Thank you so much. I'd like to invite you to give a big round of applause for our speakers today. Thank you, Federica. Thank you, Tomo. Thank you, Julie. Thank you, Eva. Thank you, Thomas. It's been a great session. Thank you for accepting to be part of it. I'm really hopeful that we'll be able to keep our commitment and also address this challenge to our audience, to do whatever is in our power in order to get to where 2030 will not be that dark as ChatGPT predicted. Thank you for being part of the session.